Intravascular ultrasound, IVUS, has several clinical indications, including assessing severity and morphology of a coronary artery lesion, determining optimal stent sizing, identifying complications of coronary intervention, and evaluating optimal stent implantation. The indications and potential risks and benefits of the procedure are discussed with the patient, and informed consent is obtained. A focused physical exam includes auscultation of the heart and lungs, visual assessment of the oropharynx, and palpation of the pulses is performed to assess the patient's risk for receiving moderate sedation. The patient is placed supine on the catheterization table with both groins exposed. Hair is removed with a razor, and the areas are scrubbed and cleaned with a sterile soap solution. Also seen here is the equipment table, which holds all of the equipment necessary to perform diagnostic coronary angiography, including catheters, needles, wires, etc. Following cleaning, a sterile drape is placed on the patient with two circular holes that provide exposure of the bilateral femoral areas. In this example, the tubing for the contrast injection system also serves as the tubing for invasive hemodynamic monitoring. This setup is similar to that of a standard injection manifold. The contrast injection system is prepared by attaching all tubes to the power injector and flushing the system with both heparinized saline and IV contrast. The first step in obtaining femoral artery vascular access is to define general landmarks such as the location of the iliac spine, pubic tubercle, and femoral artery pulse through palpation. The objective is to puncture the artery on the anterior surface, below the level of the inguinal ligament, which runs between the iliac spine and pubic tubercle. It is also customary to mark the proposed access point with a hemostat and image the groin area using fluoroscopy. The goal is to have the arterial puncture entry site to be located in the lower to mid-third of the femoral head. 1% lidocaine is administered at the skin and into the soft tissue around the access site for local anesthesia. A micropuncture technique for vascular access is demonstrated in this video. The artery is palpated with the left fingers, and the artery is stabilized between the fingers. The micropuncture needle is advanced at the predetermined skin puncture site and advanced until the artery is entered and arterial blood is visualized within the needle hub. The needle is stabilized, and the microwire is advanced through the needle and into the vessel where it is visualized under fluoroscopy to advance into the distal aorta, thereby verifying that the wire is not entering any accessory vessels branching off of the femoral or iliac arteries. The micropuncture needle is removed over the wire and a microcatheter is advanced through the skin and into the vessel. The dilator and microwire are removed, and a standard J-tipped wire is advanced through the microcatheter into the descending aorta. The microcatheter is removed over the J-tipped wire, and the standard vascular sheath, either 4, 5, or 6 French in size, is advanced. The sheath dilator and J-tipped wire are removed, and the sheath is flushed with heparinized saline. In this example, a 6 French JL4 guiding catheter will be used to cannulate the left coronary artery in preparation for IVUS. Various anatomic factors such as a lesion location and tortuosity play critical roles in the choice of guide catheter curves. Also seen here is a type of hemostatic adapter through which interventional equipment such as wires and balloon catheters are advanced into the coronary artery. The hemostatic adapter is attached to the proximal end of the guide catheter and is then connected to the hemodynamic monitoring system via either the power injector, used in this example, or a standard manifold hand injector. The coronary catheter is advanced over a guide wire to the aortic root, where the guide wire is removed and the catheter is attached to the hemodynamic and injection tubing. The catheter and injection tubing are aspirated, flushed, and zeroed. At this time, the patient is administered systemic heparin IV to achieve an activated clotting time greater than 250 seconds, which will be maintained throughout the IVUS procedure. At this point in the procedure, coronary angiography begins, the details of which are highlighted in another video tutorial. In this example, an intermediate stenosis in the ostial left anterior descending artery will be further evaluated by IVUS. In this example, a phased array IVUS catheter is used. The catheter is removed from the plastic storage hoop. The distal 1 centimeter of the catheter is where the phased array portion of the IVUS imaging catheter is located. The tip of the catheter is flushed with heparinized saline. A standard 0.014-inch coronary guide wire is advanced through the guide catheter so that the tip is positioned in the distal segment of the vessel of interest. The IVUS catheter is advanced over the guide wire through the guide catheter and into the left main coronary artery and is advanced beyond the lesion of interest. The acquisition is recorded on the IVUS console while the operator slowly pulls the IVUS catheter back toward the guide catheter. This example shows severe concentric intimal calcification of the coronary artery distal to the lesion of interest. At the lesion of interest in the proximal left anterior descending artery, there is evidence of severe concentric atherosclerotic plaque with narrowing of the vessel lumen. To interpret the IVUS images, several measurements along the vessel of interest are made. First is the distal reference vessel, which is a segment of vessel beyond the lesion of interest, which is used for normal vessel reference sizing. First, the lumen cross-sectional diameter is measured in 2 perpendicular planes. Next, a cross-sectional diameter of the distal reference vessel, media adventitia junction diameter, which is equivalent to the vessel diameter, is obtained. Next, the cross-sectional area of both the distal reference vessel and lumen are measured by manually placing dots around the perimeter of interest. The measurements can then be used to calculate percent diameter and/or area stenosis. Next, the recording is scrolled proximally to the lesion of interest where the measurements of vessel and lumen diameter and vessel and lumen area are measured and percent diameter and/or area stenosis is calculated. In this segment of vessel, the percent stenosis represents extensive atherosclerotic plaque buildup. In an average-sized vessel, 3 millimeters diameter or larger, a lumen area of greater than 4.0 millimeters squared is considered to be anatomically non-significant. In this example, although the percent stenosis is quite high, the segment of vessel involved is short in length. Because the resistance drop across a stenosis is dependent on both the cross-sectional area and the length of the stenosis, it is feasible that this stenosis may not meet functional significance. In fact, in this example, a fractional flow reserve measurement revealed that the stenosis was not functionally significant. Finally, the same lumen and vessel diameter measurements are performed on the proximal reference vessel. In this case, the distal left main coronary artery represents the proximal reference vessel. After the study is complete, the vascular sheath is routinely sutured in place until the activated clotting time returns to baseline. Once the activated clotting time returns to baseline, the sheath is removed. Once the patient is felt safe for transfer, he or she is attached to a hemodynamic monitor and transported to the appropriate post-procedure recovery area. Typically, vascular sheaths are removed and hemostasis is achieved with manual compression. Although a variety of vascular closure devices are available for use, none have proven superior to manual compression with regard to preventing bleeding complications post-procedure. In this video, sheath removal with manual compression is demonstrated. Prior to sheath removal, the area is cleaned with a sterile cleaning solution. The area immediately above the sheath skin entry site is palpated to feel for the femoral artery. While holding pressure on the femoral artery above the sheath at the approximate area of arterial entry, the sheath is removed. The area is allowed to backbleed for 1 or 2 beats, and then firm and steady manual compression is held. Underneath the skin, the artery is being manually compressed up against the femoral head, which provides a solid surface on which to assist in manual hemostasis. Care must be taken, however, not to hold such firm pressure that the distal pulses are not detectable, as doing so increases the risks of lower extremity vascular complications such as thrombosis. By rule, the duration of manual pressure is 2 minutes per sheath French size. So for a 5 French sheath, approximately 10 minutes of manual pressure is held before checking for adequate hemostasis. If bleeding is still observed after the allotted time, additional pressure should be held until hemostasis is fully achieved. During sheath removal, it is important to monitor the patient's vital signs closely, as vasovagal reactions manifesting as hypotension and/or bradycardia may occur. If hypotension is observed during sheath removal, this can typically be remedied by small boluses of IV fluid. If bradycardia is observed during sheath removal, this can typically be remedied by small doses of IV atropine.